Hello, welcome everyone back to the Integrative Health Podcast with Dr. Jen. Today we are going to talk to Dr. Morgan Camp. He is an expert in functional medicine and he really loves bioidentical hormones, longevity and regenerative medicine, chronic infections, immune therapy, detoxification, GI health, and stress-related illnesses. So all the things, and he's been working in functional medicine for about 20 years. So he's an expert. He now practices in Sedona. And he loves hiking, swimming, meditating, working out, cooking, skiing, and yoga. And is passionate about the evolution of consciousness and the interrelatedness of our health, our beliefs, and our state of mind. His education, he did family practice residency training at UCSF, and he lived in the Bay Area for quite a while and practiced there. He went and he got his MD degree. Before that, I went backwards, sorry, at Emory University School of Medicine. And then he did his undergrad in Vanderbilt University, where he graduated magna cum laude in chemistry. So very cool. And he can talk a little bit more with us about what he's been doing since then and how he's been changing lives. So Dr. Morgan, welcome so much to the podcast. So excited to nerd out with you because this interview will be intense, but you'll walk away with so much information.
Thank you, Jen. Pleasure to be here. I'm super excited to have this talk and to share what I've been doing and the successes I've been having. And it's always fun to have a great conversation with a like-minded, intelligent woman like yourself.
Oh, thank you. That's so sweet of you. Yeah, we're in a few Facebook groups together, and that's kind of how we met. And we all love learning from each other because that's what doctors used to do. They used to have grand rounds and bounce ideas off of each other. And really, the pandemic kind of shut that down, unfortunately. But so let's get right into how did you kind of go from family medicine to this medicine that you do now, which we're going to go into?
Yeah, great question, Jen. I was never satisfied with family practice, and outside of residency, I never practiced traditional family practice. Luckily, I went straight into a integrative functional medicine clinic right in the Bay Area, right out of residency, and I'd already started attending functional medicine courses in residency. And that was at a time when they didn't have many young people there. So me and a few fellow residents were welcome with open arms into a lot of organizations before they had even any training modules or anything. So I don't have certification or anything. I luckily just got to learn directly from a lot of the old timers who loved like having somebody around that was interested in learning from them. So I was very lucky in that regard. And as I've said on the other podcasts, a lot of my drive into functional medicine was around actually treating my mother. My mother had a lot of illnesses from fibromyalgia, chronic migraines, mold sensitivity, toxic breast implant sensitivity, all these different things. So, always saw that doctors weren't really helping her. And then I just kind of was just looking on the periphery, like what was happening. And she navigated it quite well. It's been quite inspiring for me. And then during my just before I started residency, I was in Nepal I took a little pre-residency sabbatical after med school. And I that's when my illnesses started. I got massive GI illnesses, and then I got chronic fatigue, followed by Lyme disease and mold illnesses and all these different things over many years. And so a lot of my path has just been discovering healers that could help me and learning what they were doing to help me, then seeing, also I've got patients right in front of me with the same illnesses that I didn't even recognize before. And hey, now I know how to help them. Yeah.
Yes, you bring up such a good point. Like you said, the patients were in front of you and you didn't know. And that's missed a lot in conventional medicine. Yes, we're trained to, find out all these chronic diseases and the medications to go with them, but really the true healing and things like environmental toxins and heavy metals, we're not taught that in medical school. And they really drive a lot of illness. And like you said, the GI stuff. Just today, I had someone, they didn't get their GI test that I ordered, the stool test, because their doctor said, "Oh, you'll go to the GI doctor and they'll order the same thing, the same kind of thing." And I'm like, it's not the same. It's not going to be what you want. So let's dive into what you love to geek out about. So first of all, for our listeners, you might have to explain what mTOR is,
Okay.
and then we could dive into how to block mTOR and the production of senescent cells. So first, with the rapamycin. So first, explain mTOR and explain senescent cells, and then you'll be able to say why and what is rapamycin, I think.
Yeah, perfect, Jen. Yeah, so mTOR, I think it's mechanistic target of rapamycin or I think it's mechanistic target of rapamycin. So rapamycin was discovered on Rapa Nui, I think in somewhere in the 1960s, I believe, in the soil on Easter Island. And yeah, so rapamycin's gained notoriety because in most animal studies in which it's been tested, it's been shown to increase longevity from worm studies to rodent studies. I think now there's a big dog study ongoing, and of course there's now studies on humans as well. mTOR is found pretty much in almost all organisms, I think above like bacteria or single-celled organisms. And so it seems to be a central component for metabolism. So when mTOR is overactivated, cells grow and enlarge and create hypertrophy. And when mTOR is turned down, then cells tend to grow less. So the way I look at it is, mTOR it's a central aging pathway, basically. And what happens as we get older is the mTOR gets chronically stuck in the on position. As it's chronically stuck in the on position and overactive, we tend to accumulate more diseases such as obesity, inflammation, dementia, etc. So a lot of this seems to be related to the overstimulation of mTOR. And what happens when mTOR is overstimulated is normal healthy cells undergo a process called geroconversion, in which they become senescent cells. So senescent cells are the zombie cells. A good description I've heard is the easiest to understand is they're like zombie cells that are the underlying cells underlying the chronic inflammation. A lot of people have probably heard of cytokine storms from COVID. So a lot of these senescent cells are producing these cytokines that we hear about. And those cytokines, again, are the chemicals driving inflammation, which are behind pain, memory loss, obesity, all kinds of things. So yeah, did that answer your question, Jen? I don't want to dive too deeply here.
Yes, that's great. So, and mTOR, it's not all bad. I mean, if you're working out, you are stimulating that mTOR if you're building muscles. But like Morgan was saying, if you get stuck there and you're chronically in that mTOR stimulation, so things that help decrease mTOR are like fasting, so that's like a easy example of that. So, but specifically, it's just so interesting because this whole process of building up and breaking down, and then what's left, that inflammation that it causes is, it was found that rapamycin, it was a target for this. So people started taking it for longevity, and people do take it for longevity. So I guess how does it work for longevity? And, is it something that you can just take for a little bit and it helps, or do you have to stay on it the rest of your life?
Good question, Jen. Yeah, good question. First off, rapamycin is FDA approved for organ transplant. So it's approved for immune suppression, which is confusing. But that is when you use it in a daily dose. When you use it in a daily dose, it suppresses what's called mTOR1 and mTOR2. We don't need to dive in that too much, but when you take it on a weekly basis, it only suppresses mTOR1, especially at a low dose. I typically use it a little lower dose than Dr. Alan Green is one of the pioneers in this. He uses 6 milligrams for pretty much all of his patients, as far as I know. And I commonly use smaller doses, especially in smaller, older patients and in women. I use typically, again, anywhere between 2 and 4 milligrams. When it's used weekly, again, it's not suppressing the mTOR2, and so as a consequence, you don't get immune suppression with just mTOR1 suppression. you get actually possibly an immune modulation and an improvement in immune systems. And it's being used and studied a lot for treating COVID and long COVID right now. And I've used it that way myself as well. As far as your second question goes about using it short-term or long-term, if we don't have any data on that, of course, but in my practice, that's often what I do. I have a lot of patients and I'll use it for perhaps 3 months, a year or so, and then give them time off. And we use it again a few, later, a year later or so. And again, that's how I treat my practice. And I just follow my intuition and the science as best as possible. When there's no science, I just, follow my intuition on this. I haven't seen a lot of side effects. The most common side effects of rapamycin are dose related. The most common one is mouth ulcers. And so as you increase the dose, I think in Dr. Green's practice, he just released a study showing that about 14% of his patients have had mouth ulcers. As far as I know, at the lower dose, I've had one patient who had mouth ulcers, and that was an elderly woman who was taking a 6 milligram dose. And yeah, I think that answers your question.
Yeah, it's so fascinating. So most people that you see in your practice, they just want to stay on this. They just take it weekly. They kind of just stay on it. And do you follow lab markers, or do they feel better? How do you know it's working?
Yeah, good question. Yeah, a lot of the work I do doesn't necessarily have good lab parameters. The lab parameter we would want to look at would be related to, in my opinion, would want to be looking at senescent cell markers, and those are not clinically available now, as far as I know. I have a lead on a lab in Georgia that supposedly does it, but I haven't been able to make that happen yet. So the way I think of it is rapamycin is sort of like starving senescent cells. So it's turning the food off to them so they don't get fed. There's also senolytic treatments where you can directly kill the targeted senescent cells, just like you're taking an antimicrobial. The lab markers to follow, I follow in everybody, hemoglobin A1C, CRPs, these sort of markers. So I follow those in everyone, as well as lipid markers. There is a concern that perhaps rapamycin raises the lipids in a certain subset of patients. So I follow that and monitor that. I think I've seen that in 1 or 2 patients as well, where the lipids are higher. But other than that, nope. My practice is mostly, I have two, when I'm treating patients, of course, I have patients who come in for acute problems and chronic problems. But even when I'm treating those, I'm also thinking, how can I make them better in the long term? What can I do to help with their longevity? And even if we're treating an acute or semi-acute illness, like what role are those senescent cells playing? How can I treat them with peptides? How can I help them in the long term while we're trying to overcome that short-term problem as well?
Yeah, and talking about peptides, a lot of the times you have to before you use specific peptides, you have to clear out those senescent cells. I mean, we got to take out the trash. You can't just have these zombie cells, laying around. And it's when they get stuck and they just can't, the cells can't clean up their own garbage. That's what these senescent cells are. And that's when they cause that inflammation and everything. And I love that you brought up markers like CRP and lipid panels, because those are signs of inflammation. And easily people listening could ask their doctors for a lipid panel or a CRP, which is a C-reactive protein. And if those are high, your body's on fire and inflamed, and you probably need to clear out some senescent cells. So you mentioned some Senolytics, and there are some different supplements that can do that. I take a Senolytic, usually 2 times a month. I do it mid follicular phase, because that's when I know it's not going to stress my body out too much. Because that's the thing, you don't want to take a Senolytic or certain peptides that are going to clear those. You don't want to take them all the time every day. You need to give your body a break. So could you go over some of the different Senolytics and how to clear these zombie cells out?
Yeah, happy to, Jen. Yeah, first off, the treatment you're referring to, the scientists call it hit and run treatment of senescent cells, meaning you just target the treatment. The least frequent I use is perhaps 2 days a month. And that's typically with like dasatinib or dasatinib with quercetin. I'm pretty sure I'm pronouncing that drug wrong. Dasatinib is an FDA-approved medication that has been studied quite a lot by Dr. Kirkland and his senescent model. So the primary treatments I use are dasatinib with or without quercetin. There's also an experimental peptide created at the Buck Institute called FOXO4-DRI. That works in the P53 pathway, which, if my memory serves, it would be very, very fruitful for preventing cancer. I'd love to see research on that. I think that I have a lot of experience with FOXO4-DRI, and I've seen a lot of people benefit from it. I've had a friend who had some memory issues from long COVID. One dose of the FOXO4-DRI, and her memory's back to normal.
Wait, one dose?
One dose. Yep. It's
Oh, now I'm intrigued. I've dabbled in that peptide a little bit into the research, but haven't used it yet on anyone. Have you personally used it?
Yeah, I've used about 6 to 8 rounds of it. So I dosed that one like Monday, Wednesday, Friday, every 4 to 6 weeks with a dose from 0.5 to 1 ml. And it's very expensive. Anybody who's selling it for cheap is not giving you the real deal. It's DRI means you're only taking half of the mirror image of the molecule. So it takes a lot of work to get the mirror image perfect. So that's not one you want to skimp on and find a cheap version of. There is no cheap version of it. But again, it is experimental, not FDA approved, but I have, personally used it and had great success with it. I had severe case of long COVID with POTS syndrome and mast cell activation and very severe memory loss, which has all been rectified and mostly reversed with these senolytic treatments, especially because COVID acts to increase the senescent cells, and that's why it attacks the elderly and those with dementia and those who are obese, because they have more senescent cells. So it actually attacks the senescent cells, increases the number of them, and increases the release of those cytokines and what's called SASPs, which are cytokines and other inflammatory chemicals. So in my long COVID program, the treating with senescence is a big part of that. There are also herbal formulas, which I'm using more and more now, and that they mainly have in them quercetin and fisetin, and there are a few other as well. Fisetin, can come from several sources. The one I always remember is wild strawberries, but you have to have pounds of it to get there.
Yeah.
And quercetin comes from
strawberries all day.
Exactly.
You would just eat strawberries all day, to get the amount.
Exactly. So when I use the herbal formulas, I do typically prescribe those more frequently, maybe like twice a week or so. But again, not forever for any of these, because again, and you don't use them when you're young and healthy necessarily, because again, you don't want, these are natural, mTOR and senescent cells are naturally present and naturally serving certain functions. So you don't want to modulate them unless you really know what you're doing. Or at least have a good idea of why you're doing it and monitoring it and knowing when to start and stop, etc. One interesting thing with these senolytics is they're very similar to actually treating an infection, in my experience, and meaning that they produce similar to Herxheimer reaction and die-off reaction, especially the first few rounds. So it's very common you feel worse when you take these at the beginning. And there's a study of senescent cells that is really interesting too, to back this up, that the diseases are almost like an infection. So they're in a mouse study. They took old mice with, I forget, some chronic disease like arthritis or diabetes, etc. And they pulled out senescent cells from those mice and put them in young, healthy mice. And the young, healthy mice within 2 weeks had the same diseases as the elderly mice did. So it's really interesting that it is really almost like an infection. And when you treat it like that and target these with these senolytics, you get a die-off just like an infection, and then typically start getting better and better. Yeah.
Yeah, well, it's really interesting because I have seen lots of acceleration of diseases with COVID and with the COVID, jab. So, and that's this accumulation of senescent cells, along with that spike protein it's kind of crazy. And interestingly, you said, this is helping clearing the senescent cells, helps so much with this long haul. And then, it's also been studied and recommended that fasting is really helpful for long haul. And that's also helping clearing that. So if a lot of people are out there listening, they're like, oh my gosh, all this sounds so expensive. Then what could they do? They could fast, that's free. That's the nice thing. So tell us how fasting accomplishes this.
Well, not only free, but you're not having to pay for food, or, you get a couple extra hours in the day too, not having to find the food and eat it, right?
Right.
Good.
Yeah, it is. Fasting days, like when I do a longer fast, I'm like, oh my goodness, I don't have to think about food. It's crazy.
Right. So I am no expert in fasting. I've done a lot of it myself in the past. It's a harder one to a lot of patients don't have the time for it, unfortunately. But again, what fasting is doing, the same thing that the rapamycin is doing, is it's stimulating autophagy, or mitophagy in mitochondria, which is what you were referring to earlier, meaning that cellular cleanup, taking the trash out. So when that mTOR is overactivated, cells hit that end-stage senescence, and what that means is they can no longer repair themselves. So our cells are constantly cleaning and repairing themselves, and when they can't do that, that's when disease comes. So fasting takes a lot of energetic load away from the digestion process and allows us to focus that energy on cleaning the house instead.
Yes, and that is all very important. So after we clear out these senescent cells, then you like to stimulate and encourage the mitochondria to kind of get back into it and get repaired. So what are your favorite things for that?
Yeah, a lot. And also, I'll use the Senolytics also before things like stem cell treatments and exosome treatments and things like that. But also because these Senolytics will turn those stem cells into senescent cells as well. So you get these expensive stem cell treatments, you got pain, inflammation, senescent cells. Guess what? You can actually just create more senescent cells. So I think it's wise. I don't have any studies to prove this or data to prove this, just my own intuition that this makes sense. So after we clear some of the senescent cells and encourage that mitophagy, where the mitochondria are cleaning themselves, so we're sort of like pruning the weeds out of the garden before we fertilize it. So then I fertilize it with all kinds of things. So, from starting with the free things, exercise, like high intensity interval training, that'll get your mitochondria going. Red light therapy. There's a lot of good red lights, many different brands, and 15 to 20 minutes of those a day work really well for increasing mitochondria. I use technology like pulse electromagnetic frequencies as well. That's helped me personally a lot with aches and pains and herniated discs, etc. And then, on the peptide front, and got a lot of mitochondrial peptides from SS31 to MOTC. One of my favorites in the last 6 months or so is 1-amino 5-MQ, which again is an oral treatment. It's relatively expensive as well. But I have patients, I put them on 6-week courses of it, 8-week courses of it, then give them some breaks. So it's not something you have to take continuously. But I find that works really good for increasing muscle mass and helping burn fat and get mitochondria going as well. And of course, I use, a lot of different peptides and bioregulators as well to do this. What are some of your favorites, Jen? Did I miss any there?
Yes. So I love 5-amino 1-MQ. I use that a lot. I personally, I have it in my work bag. If I'm feeling a little sluggish during the day, I'll take it, give my mitochondria a little energy. I use it when I travel. It always comes with me when I travel for jet lag. Everyone, I had to go to near you. I had to go to the West Coast, and just the jet lag, it's no joke. So that really helps a lot. And yes, I'll use it for patients that, I just don't want them on semaglutide, or I want to get them more optimized before semaglutide. I'm really picky about candidates for that peptide, and I'll give them 5-amino 1-MQ. Helps with energy. Yes, that lipolysis. And it's the mitochondria. We have mitochondria in all of our cells, and it has gotten trashed with this pandemic. And our mitochondria gets trashed with, bad food, inflammation, just the American lifestyle, I guess. So I love 5-amino-1-MQ. I think it's a great one. MOTS-C I use occasionally. My cat was running around, our stray cat, we named MOTS-C. I named her that. It's such a cool peptide. So for the mitochondria, and it's used a lot with kidney. That's where I tend to use it more with patients with early kidney issues, because it helps the mitochondria in the kidneys. So when we think about kidney disease, one of the docs I had on the podcast before, Dr. Robin Rose, she believes, it's the mitochondria in the kidney. That's why it's a mess. So, I think that is the problem with conventional medicine is, I don't think I've ever gone to a conventional doctor, with all my thyroid issues and everything. I don't think anyone's brought up the word mitochondria to me. I think that kind of got skipped right after like 6th grade. You make that little powerhouse of the cell with the little lines, and then we forget about it, right? So, okay, SS37, SS31, sorry. I've used that in some chronic Lyme patients, chronic infections. I haven't just used it for mitochondria, so I'm curious on what you've seen.
Yeah, I haven't seen amazing results with it either, honestly. I've seen much better results with MOTS-C and 1-amino-5-MQ without the need for injection. And the SS31 is a lot more expensive, to have a round of that than the 1-amino-5-MQ. So yeah, that's been what I've leaned to more in the past 6 to 12 months or so. Yeah.
Yeah, that's great. And also mitochondria, just supplements too can support. We do need to just do basic supplement support. You had suggested Freeform amino acids. Can you tell us a little bit more about how you use those and what they are?
Yeah, well, there's different amino acid blends. I think a lot of the original research on that was from Dr. Richard Lord at what's now Genova Labs. I forget what it was before then. But yeah, he's worked a lot, and I'm good friends with Dan Kalish, who studied a lot with him. So Freeform amino acids, one of the benefits they do is they do stimulate TOR. So they really stimulate TOR. So once you've already pruned those mitochondria in the cells and the autophagy all done, then you can sort of rev them up with Freeform amino acids, which provide a lot of energy and a lot of direct stimulation, probably increasing the mitochondrial quality and quantity. And so I find that very useful, and it's really easy. There's many different brands out there. They all have somewhat different formulas, and they all have a little bit different tastes. But typically just, 2 to 3 servings of those on an empty stomach once a day work really well for stimulating mitochondria and energy production. And yes, of course, I also, when you're looking at the Krebs cycle, you got to look at B vitamins, coenzyme Q10, all of those. And I use organic acid testing for most of my patients just to help pick out which of those vitamins is needed, because I'm super sensitive myself, as are many of my patients. And if you give me the wrong B vitamin or too much, man, my brain and circuits just go haywire really quickly. So I used to guess with those, but I don't like doing that anymore.
Yeah, you can definitely get overstimulated. You can move that cogwheel too fast, and just it's no good. So that can happen to people, is they start a B vitamin, they think it's going to help, but they end up being like anxious on it. So that means you need to dial it back a little bit. So yeah, I like taking amino acids. I just take them right after a workout, muscle building workout. So that's what I do. And it's just kind of my routine now. Right after I work out, I take these supplements. So that's a really good way to just support that. Now, the other thing that you had brought up was HIIT training, and that's high intensity interval training. Now, I have a love-hate relationship with HIIT training, because a lot of my Hashimoto's patients, they are just like burning out their adrenals. They're just so I barter with them. I say, let's heal your gut. Let's balance your thyroid, get your Hashimoto's better, and then you could go back to it. And I like them to do their HIIT workouts. They can do it. I prefer the first half of their cycle. And then after, a couple days after ovulation, I don't want them to do HIIT workouts and crazy, crazy things. Now, men, because you have this 24-hour, cycle of hormones, you guys can do whatever you want. But for women and my really sick autoimmune patients, the HIIT workouts, I kind of like, I'm not a fan of Orange Theory at all. Do you know Orange Theory?
A little bit, yes, a little bit. I've
Yeah.
never been. Yeah.
Yeah, I've never been there, but it's all about like who can get the most splat points. So me, if I went into there, I'm super competitive. I would just do like, all the HIIT workouts, and I would be trashed when I came out. No, but in all seriousness, I tell people with the HIIT workouts, yes, they're good, but it needs to be personalized, like everything. So how specifically do HIIT workouts, how do they support the mitochondria? And would weightlifting do something similar?
Good question. Yeah, so I've had a lot of those adrenally burned out patients, many of which I used to treat a lot of like professional triathletes and marathon runners and cyclists. And yeah, so for them, like a HIIT was actually easier on their adrenals than what they were doing before. So it was a compromise. Yeah, it's a compromise to get them in there. One of the reasons I really like HIIT is because it's increasing, testosterone and growth hormone production when done well. And yeah, how do I customize it? When I have people that are burned out adrenally and fatigued, I just ask them, they have to be very honest with themselves. Do you feel, when you exercise, do you feel any worse that day or the next day? And if you do, you did too much. It's really simple. You have to be in integrity with yourself. But it really is that simple. So I'll tell some people with HIIT training, hey, just like, 4 cycles of 15 seconds. 15 seconds on, 30 to 60 seconds off. Just do that 4 rounds, take a break and do it again. So you only exercise for like 2 minutes. But for a lot of patients, they get a release from exercise and they're sort of addicted to that release. And so, trying to find that compromise where they can have that release and also not harming themselves, that's the art of practicing medicine, right?
Yes, it definitely is. I have to work out. It feels good. I need to, or I'm grumpy. I joke, but I'm not really grumpy if I don't work out, but maybe. Have you seen those like smart bikes? Do you know what I'm talking about? Where you only do like kind of like you were saying, a 2-minute workout, and it adjusts for you and you get like maximum VO2 max. Do you know what I'm talking about? Those smart bikes?
I've heard about them, but I have not witnessed them. No, I haven't. Yeah, I haven't.
Either.
And I didn't answer your question about the weightlifting. Absolutely, weightlifting for adrenally burned out patients, that's absolutely the best, because you're not using a lot of cortisol to lift weights. So you're not you're not consuming all your cortisol. So absolutely, weightlifting will also, of course, stimulate this testosterone and growth hormone production and get the mitochondria going as well. Absolutely. Yeah.
Yeah, so you brought up growth hormone a little bit. So the next step that you, in your kind of thought pattern, is optimizing hormones. So talk about what you like to optimize, and and we could talk peptides fit in here too. So
Sure. Yeah. Yeah. So I've been working with hormones my entire career. I had some early patients come in who had so many abnormalities. And when I was first starting out 20 years ago, there was not many people doing this. So, I mean, everybody had Hashimoto's then. Like every other person that walked in the door had Hashimoto's. Was like, oh my goodness, and nobody's treating it. So I soon became, had to become an expert in thyroid and other hormones. And I had male patients come in who were like, oh, I'm super depressed and anxious. I don't know why. And we'd look at their testosterone and it's in the toilet, and we'd raise it up and they feel better. I'm like, well, this is pretty easy, actually. So, so I started treating that, and that's the basis on which I treat most of my patients. If the hormones aren't balanced, it's going to be harder to get leverage anywhere else in the body. And as far as peptides go, yeah, my favorite for growth hormone is CJC 1295 with ipamorelin. I've been using ipamorelin mostly with sermorelin since probably 10, 15 years ago. I wasn't able to get CJC that back in time, but I was using high dose sermorelin with the ipamorelin, getting very, very good results. And the CJC is working similarly, just a longer acting, so you get even more growth hormone production with that. Do get great results with that. For those adrenally challenged patients whose cortisol, whose stress tolerance is super low, and get frightened and anxious and traumatized very easily, I find better not to give them growth hormone too quickly. Otherwise, it might lower their cortisol, because all hormones have interrelationships. As we raise growth hormone, it does put a little more stress on your body, and so you need to be able to raise cortisol a little bit to meet those demands. And if you're not, you will bottom out in cortisol and perhaps have more anxiousness and insomnia, etc. But on the average, relatively healthy patient that I'm treating, most people love CJC with ipamorelin because growth hormone leans you out, it helps you burn fat. And it's a very healthy way to burn fat. So when you exercise and you use the CJC ipamorelin and burn fat, you're losing all that inflammation that's coming from those fat cells that are driving a lot of the disease processes in our bodies.
Yeah, it's great. And that's the thing, not a lot of people know how to use it or know a lot about it, like practitioners. And it's one of my favorite. And I dose it, 5 days on, 2 days off, just at night. Sometimes for some people that don't like to give themselves a shot 3 times a day, but you could use it up to 3 times a day. Usually it's like morning, and then if you want to use it with a workout, and then it's nighttime. And I've personally used it and love it. I sleep so well when I take it. So have you personally used it?
Oh, absolutely. Absolutely. Yeah. And do you use it pre or post workout?
Well, that's the thing. I've always used it post. Is that how you? And that's how I prescribe. Yeah.
Yeah,
Okay.
exactly.
And
Yeah.
yeah, and that's what I tell people. So I like to use it in long haulers. Some of them that I've seen, they're really sick and they've lost a lot of muscle mass. So, in my male patients that need more muscle mass, I don't want to jump to testosterone all the time, because a lot of these men, they don't keep testosterone. Testosterone goes to 5 or DHT, I'm sorry, through the 5-alpha reductase pathway, it goes to estrogen. So sometimes if they need to build muscle and lean out, and remember, building muscle will give you more testosterone. So, and I think men are like, oh, testosterone. And I'm like, are you doing squats every day? If I can squat more than a male, then that's a problem. And I can, like, a lot of them. And I'm like, well, you need to work on building your muscle. But then it's kind of like a catch-22, because if you don't have any testosterone, it's going to be harder to build muscle. So that's where this growth hormone comes in. And this is not like a legal growth hormone, and it's not technically growth hormone. It releases growth hormone. So peptides are chains of amino acids that elicit a response from the body that is a natural mechanism. So I forgot to have us go over that in the beginning, but yes, you're not going to be Barry Bonds and like grow helmet sizes. Your hands are not going to grow, right? I mean, some people think about that, right?
Absolutely. Yeah. The most common side effect I've seen, and I've only seen this in a couple people, is like wrist swelling, like carpal tunnel. So one of the first signs of excessive growth hormone is swelling and symptoms like carpal tunnel. You can get flushing when you inject it, and you can get itchiness at the site of injection as well.
Yeah, I've had 2 patients only that have had to stop because they get that rash at injection site. So I switched them to, oh, no, I forgot. I think just tesamorelin, possibly. I'd have to double check, but I switched them. But when we think about growth hormone, this is something that is you're rocking it with growth hormone in your 20s when you're feeling good. And then as we age, it goes down. So this is kind of a lot of what, Dr. Camp and I do, is just longevity and you're older, but you feel better than when you were in your 20s. Because I do. I don't know about you. Do you feel better than now that you know all these hacks?
Absolutely, absolutely, absolutely. And if there are times and I feel worse, they're brief, much briefer than in the past. Absolutely, much more resilient and yeah, recover quickly to everything.
Yes. Okay. So you brought up flushing, and that came to mind, melatonin. Can you talk a little bit about that peptide?
Which one?
Melatonin.
Melanotan?
Yeah. Sorry. Yeah. I say it differently. Sorry. Go
Oh
ahead.
no, no, yeah. There was a little
Yeah.
glitch when they recording at the same time. Yeah, yeah. Oh yeah, melanotan. I use that one. I don't use it a lot because of the tanning. The tanning from it. But it is good. I do use it for some patients who want to, who are going on a tropical holiday in the middle of winter and don't want to get sunburned. Melanotan's really good for that. Melanotan 2, and also increases their libido while they're there, and it kind of lowers your appetite. So if it wasn't for the tanning from melanotan, it would be a really spectacular peptide. But unfortunately, the tanning can also lead to like sunspots and a lot of color discoloration.
Yeah. People worry about that.
Yeah, yeah.
So what about targeted weight loss and insulin resistance? Which insulin resistance is becoming so common. It's bananas. So what are your thoughts and approaches to that?
Yeah, good question. Yeah, I created a holistic weight loss business in the Bay Area and still direct it. So yeah, I have a lot of experience with that. A baseline, I help, it's first of all, of course, diet. A lot of it may be underlying candida, mold issues causing insulin resistance. Of course, it's processed foods, etc. So a lot of working with diet, of course, but assuming that's okay, then I've been using metformin for many years, and I find for some people that will lower the hemoglobin A1C a couple of points and help them lose a few pounds. I haven't had a lot of people who've like lost all their desired weight just using metformin, but of course I like to optimize hormones and thyroid. And then when you do that, then it's easier to lose weight with any other treatment that you use, including metformin. I've also used, berberine and other herbal formulas with some success, nothing great. In the last few years, I have, of course, used more semaglutide as well. And I've even, some patients who just have like insulin resistance and not necessarily a lot of weight gain, we can use a really low dose semaglutide just to bring the hemoglobin A1C down. I've seen pretty good success with that. So a lot of my patients are sensitive to semaglutide, and the high dose just causes too many problems for them. So I typically use low dosing for the semaglutide as well as, a lot of the other treatments that I use. So I find it's often beneficial to treat in most everything I'm treating. I find it beneficial to try to target whatever I'm doing from several angles. So rather than one treatment, a really high dose where you're more likely to get side effects, a little of this and a little of that seems to go a lot further with a lot less side effects. In my weight loss clinic, we also use MIC injections with B12. That's methionine and acetylcholine injections. I just use those because I felt I was like, well, let's see, at least give people energy. And then I did analysis on patients, and we had enough data where like I studied people over months, and like people that weren't on anything else, just diet changes and the MIC injections were losing a few pounds a week. It didn't start until about 4 to 6 weeks in the therapy though. And so it was really interesting. So you got to give it for a while before it really kicks in. And of course, the more frequently you give it, the better. And it is an injection. I haven't tried any of the oral forms of it, but I found that to work very well. So, diet changes, HIIT, exercise, metformin, semaglutide, berberine. I follow hemoglobin A1C in all my patients, and that's one of those big. It's like C-reactive protein. If those are elevated, your risk of all diseases is elevated, including cancer, heart disease, everything. So, as a longevity doctor, I want to keep all of those as low as possible.
Yeah, I check a lot of home IR scores, so the fasting insulin.
Yes.
That's kind of my favorite, because then I'm like, whoa, oh, you're fasting insulin, it's above 5 or it's 10, and we got to get that down. And I utilize a lot of continuous glucose monitors in my office. I don't know if you use those a lot. And that feedback, I have one on now. It expires today. I share my own data with my social media, my patients, because I can make mistakes and I like to test things out, and it's really fun. So I think that that's also really important. Now, let's go back to semaglutide because it's such a hot topic right now. So we've been using it in our practices. We've known about it kind of longer than it got like super trendy. And so people are always like, what do you think? Because I'm more integrative, more holistic. And I'm like, well, the people that are just getting it from any shop, or they're just going online and ordering it, which is, I think, inappropriate. These doctors that are just turning it out just for money, that when they get off of it, they're going to gain the weight back. And it's interesting. One of my friends, her mother lives in Florida, and they were told that they were going to be on it the rest of their life. It's really weird too, because they have to come into the clinic to get their shot, where usually you should just get it mailed from a compounding pharmacy to your home. It's your vial. Your doctor shows you how to use it. So very strange. So for me, like any peptide, this should be something that you're on for a little bit and then you're off of it for a while, and you should be cycling it. And this is the same with adaptogens and probiotics. So for me, semaglutide is one of those where I've had patients come in specifically ask for it. I'm like, you know what? Let's work on your gut health, balance your hormones, and then we'll get you on the semaglutide for a few months, see how you do, lose the 10 pounds, and you're not going to gain it all back. And sometimes I transition them off semaglutide and I do the 5-amino-1-MQ. So then they're cutting their cravings. Because I had one patient, she looked amazing. She lost so much weight. She got a little bit of that face problem. She looked so thin, but we did some microneedling. She's good. And she was so nervous about the holidays that she was just going to go back into like kind of eating and just, she was nervous about it, because semaglutide kind of breaks that food chatter constant that you have, and really remodels relationships with food, which I think that's a positive. But I put her on the 5-amino-1-MQ, and she did really well throughout the holidays, and she's maintaining her weight and building muscle now. So that's another non-negotiable I have for semaglutide. They have to promise me they'll eat protein, prioritize protein, and they have to promise me that, we don't like pinky promise, but I'm like, come on, this is for your health. They have to promise that they'll lift weights. So yeah, how do you handle semaglutide? Because I'm kind of curious, because I'm very about it, and my patients appreciate it, but I'm like, they could just go get it from someone else down the street. But I think they know that I'm not doing this just to do it. I'm doing it for their health.
Absolutely. Yeah, I think of it like a crutch, right? You want to use it for the intended effect while you're also getting therapy. Like you go to physical therapy while you're using the crutch, to get better. So, in this analogy, we're the therapist and we're helping heal whatever caused the weight gain in the first place. And I'm adamant on that with all my patients around all the things I treat. You got to work on the why do you have it? Why is this coming up? And why is it so hard to treat? What's the underlying factors? Is it emotionally, stress, familial, etc.? What are those that we can treat? And everybody's different, and more people, everyone has different inclinations and abilities to treat or to go within themselves and have different parts of themselves healed. But usually, with enough options, we can find something that works for everybody. And absolutely, I like that, got to go build muscle. And that's critical for the listeners out there. When you're taking semaglutide, the biggest thing I see is people getting low blood sugar because they're not eating enough protein or enough period, and they'll get dizzy, they'll get lightheaded, they'll pass out even just because they're forgetting to eat sometimes. And you got to remember, your brain needs glucose. I mean, it can survive off ketones, but it takes a few days to get ketones going. And in the meantime, if your blood sugar is dropping, you're starving your brain, and starving your brain is not good for anything, for any of us.
Especially if you're jumping into it and you're not metabolically flexible yet. So, and that's why I have a lot of patients wear continuous glucose monitors, and they find out more and more their anxiety is linked to their blood sugar, roller coaster and how they're feeling. So oh my goodness, I think everyone should be on a continuous glucose monitor, at least for like 1 month in their life, right?
Yeah, I love that.
So
Which brand do you find certain brands are more useful for the
I
CGMs?
just I just usually do the Libre 2. It gets pretty good coverage. I can see what they're doing. They sign up and then I can see their graphs. It's interesting though, because mine is always like 10 to 20 points higher than my finger stick, which is going to be more accurate. So I don't really use mine to see my number. I do it to see like, am I flat? Am I spiking? And people will see you will get spikes from exercise, from sauna. The cold plunging drops my glucose. It's kind of cool to see on my monitor.
Oh,
So,
interesting.
well, because I'm shivering so much and that brown adipose tissue. Yeah, it's cool. But I geek out on that. Oh, one other peptide I want to discuss. What probably let's just talk. What are your two top peptides or top one? I don't know. I guess top two. CJC. It's one of my favorite from Moreland. And then BPC 157. Do you utilize that a lot in your office?
Yeah, I do. I usually use that with like a thymosin beta extract or KPV.
Mm,
Especially if you're treating GI issues, BPC with KPV can be very useful because KPV it's a very powerful anti-inflammatory, and it's very useful for mold and candida related inflammation as well. You have to be careful. Too much KPV can stimulate mast cell activation, and I personally overdid it when I had long COVID and got some mast cell activation, so I learned that on myself. But I was taking negative.
Where are you talking about too much how much KVP?
Yeah, I was taking it orally and in a nasal spray and injection. Don't do that.
Okay.
Don't do that.
Yeah, because usually just 500. Yeah. Yeah. And that's what's cool. These peptides you can take them orally. Nasal spray, you said, then you're gonna possibly cross the blood-brain barrier is what we hope for. And then injection. So BPC 157, if there's an injury in my household of 6, we keep that in the fridge. So it's a great. Well, it's crazy though. No, the injectable.
Okay.
I have oral BPC too, but yes, for GI stuff. But what's crazy is, so BPC 157 is banned in the NFL and all of these places. And it's interesting because it's like, well, how would they test? How would they know? We make BPC 157 from the parietal cells in our gut. So it makes me mad because it would help athletes recover and actually heal, but instead they give them steroid shots, which destroys their ligaments. And I cringe. All patients come into the office and they're like, oh, since I saw you last, I had this like knee or elbow thing or shoulder thing, and they're like, they gave me a steroid injection. I'm like, do not do that ever again. You have an injury, you call my office and we will inject BPC 157 because steroids, it's a quick fix for inflammation, but it's ruining your joints. That's my pet peeve. That's my soapbox.
Yeah, I was trained in prolotherapy and PRP. And so I've never been a fan of maybe one steroid shot for some people with certain conditions. If that solves it, great. Some elbow conditions are like that, but otherwise never. So I agree with you. Can I ask you what dose of the BPC when you're injecting for musculoskeletal issues?
Oh gosh, I'd have to look because mine's always the same. So I use 25 units.
Okay. Yeah.
I'll have to get back to you.
I'm pretty sure we're using the pharmacy, so I know what you're using. Okay.
Yeah. Oh yes. Okay. Yeah. So 25 units, and sometimes I'll do them in like trigger points around there. PRP. That's another good thing to talk about for joints and also cosmetically. And this is something that it's frustrating because orthopedic surgeons won't mention it. I had a patient that had to get ACL surgery and luckily I saw her that same week, and because I don't think that I could have like given her input, but I said to her, are you getting PRP injections since you're going under? I know specifically the surgeon because I had to get PRP for my torn meniscus, and I was like interviewing different people in the area. And he said he would only get insurance coverage if it was during a scope or a surgery for that. So I told her, I'm like, ask them if they can add that on to you, and that will help your healing and regeneration and everything. And she did, and she was so happy, and they did it. But why is this not standard of care? It's kind of bizarre because there's actually a lot of research out there on this with joints.
Yeah, good question. Yeah, I have no idea other than, just status quo and people making a lot of money at the top, not wanting to change. In the Bay Area where everything, where I learned and trained until recently, it's super cutting edge there. So all the orthopedists now do PRP. They all offer it because otherwise they'd be out of business now because all the other doctors are doing it. So they had to go to it. And, hopefully this doesn't offend too many orthopedists out there, but if you want to get PRP, don't go see an orthopedist unless they've had good training. And most of them are, the ones I've met are super cocky. Oh, yeah, I can do that. They watch a 5-minute video and they think they know how to do an injection. Well, it's different cutting somebody open in the operating room versus knowing how and where to stick a needle in someone's joint. It's very different. I've been trained by the Hackett-Himmel Foundation for Prolotherapy, and those guys, they did it before ultrasound or any x-rays. I mean, we're sticking 3-4 inch needles in people, and you better know what you're doing when you're doing that, otherwise you're high risk there. So that's my advice to your listeners out there. Find somebody who's well trained in prolotherapy, PRP, etc. Usually the musculoskeletal docs, the osteopaths, or the physiatrists are usually the best at that in my experience.
Yeah, absolutely. Are you doing any BPC 157 and intra-articularly?
Oh, absolutely. Yeah. And I have friends who run, stem cell clinics and PRP clinics, and I don't do these injections anymore because my clinic's virtually. And also they're so good at it, and they have the ultrasound and all the devices. And I'm like, I just tell my patients, go see them. And, sometimes we'll give the docs a vial too and say, hey, can you put this in the PRP? And they'll usually do it as well. Yeah.
Nice. I was just going to say, I'm going to fly to Arizona to have you do some more PRP in my knee for me. I don't think I need it now. BPC 157 is keeping me good, but
yeah,
yeah, I mean,
I've got a great sorry to interrupt. I got a great osteopath friend here now who does great injections too. Yes, if you ever want to come out, we'll hook you up.
That's good to know.
Yeah.
Yeah, and I mean, this is stuff like what didn't Payne Manning? He went into the stem cell route. So this is stuff like, so I'm in Northwest Ohio, which is just like, opposite of the Bay Shore, the Bay, I mean, so this is where, patients around here, clients, they need to kind of advocate for themselves and ask questions and ask for things. And that's one of the reasons why I do this podcast, is so people can know what's out there, right? I'm sure a lot of listeners haven't heard of these peptides. They're probably like, what are those letters? And you just have to find someone that's well versed in it. It sounded like alphabet soup when we started to, right?
So,
I mean,
it still does.
So yes, some of it, we have this awesome peptide group on Facebook, and it's so good. It just really makes me learn, makes me read more and find out the newest best things, so patients can get better and their body can heal themselves, because that's what it's about. So Dr. Morgan Camp, thank you so much for being a guest on the podcast. I knew this would be a great conversation, and I'm sure a lot of people will want to listen to this in normal speed and not 2x, because there's a lot of nuggets in here. Can you tell everyone how and if they can work with you, where to find you? I'm going to link your website, just if you hang out on social media, where they can connect with you, all the things.
Good question, Jen. And yeah, thank you very much for having me. This has been fantastic. I learned a lot, and it's always good just to find like-minded people to talk with. It's fun. It inspires me. Yeah, my website is very easy. It's drmorgancamp.com, drmorgancamp.com. And yeah, if you're interested, there's a welcome call button there, so you can book a welcome call with my staff and tell you about my practice. I do offer consultations and non-physician appointments, meaning I'm counseling counseling people for things like second opinions, or, oh, maybe this is a better way to look at your illness, and maybe this is how you can find a better doctor than the one you're working with now, or that sort of thing. So I do offer that. I have several programs as well. So yeah, if you're interested, go to my website, take a look, and thanks again, Jen.
Yes, that's awesome. I will link everything below. And thanks, everyone. Give us feedback, leave in the comments what you thought, and maybe we could have Dr. Camp back on and we could dive deeper into the peptides and stuff if you guys want to nerd out more. So thank you so much.
Absolutely. Love to come back. So thank you.